Good morning, good evening from Miami. This is Dr. John Bennett for Neurosurgical TV. We are televising the conference, a neurosurgical conference for the Immense Society of Neurosurgeons. Again, today's the second day, and today we have Victor Hugo Perez, MD, a famed neurosurgeon, neuroanatomist from Mexico City. And Victor's going to talk today about the anatomy of the spinal cord. And also we have a few guests. Hello, Marco. Say hello quickly.
Hi, good morning. I'm from Bolivia.
Okay, welcome, Marco. Welcome, Marco. Okay, Victor, it's all yours.
Okay. Let's go to talk about the surgical anatomy, vascular anatomy of the spinal cord. As you know, Albert Adamkiewicz was the first to inject some veins and arteries of the spinal cord. What he did, he injected arteries and veins of the spinal cord, applying a special method using Teichmann mass, which consisted of ammonia, zinc white, linseed oil, mercury sulfate, or carmine sediment for the red color of the arteries, and Prussian blue for the veins. It was about 150 years ago. So he discovered the great radicular spinal artery known as Adamkiewicz artery. This is a draw that he did after his injections. In this drawing, you can see the vertebral arteries and the anterior spinal artery. Now we are doing the same, but with a special injection, silicone injection in red color for arteries and blue for veins. Nowadays, we can get some beautiful photographs about this. In this case, you can see the vertebral arteries. One of them is hypoplastic, the right vertebral artery hypoplastic, and the left is giving rise to the basilar artery. The artery of Adamkiewicz traveled with the ventral root to the ventral surface of the spinal cord, where it took a characteristic hairpin turn caudally. This is a picture about this Adamkiewicz artery. This is the principal artery that is giving rise to the vascularization of the lumbosacral segment of the spinal cord. The irrigation of the spinal cord is heavily dependent on the artery of Adamkiewicz and branches of the vertebral arteries. This artery is of enormous clinical, surgical, and radiological importance. Here we have the posterior aspect of the cerebellum and upper cervical spine, and the first dorsal roots of radicular nerves. Here we have a picture of the Adamkiewicz artery. In the superior photograph, we are seeing a very small thoracic artery. Look at the difference in the size between the thoracic artery and the Adamkiewicz artery. The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. The anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. I have studied almost 50 spinal cords. What I am showing you is the statistics of this work. In these pictures, we are seeing the highest level of the origin of Adamkiewicz artery. This Adamkiewicz artery is arising from T3. You can go through all the nerves, beginning to the upper segment, C1, C2, C3, C4, C5, C6, C7, and then T1, T2, T3. And this is the highest level of this Adamkiewicz artery in my work, in my research in these arteries. In the lower picture, you can see some the origin. This is really beautiful. This artery is the highest level. So the lowest level, as you can see in this picture, is arising from left L2. This artery was the lowest, left L2, the lumbar 2 radicular nerve. This is a lateral view of this artery. We are displacing the nerve roots, and you can see in this picture the posterior spinal artery. Drawing obtained from an original article by Adamkiewicz, published in 1881-1882, showing arterial vasculature of the spinal cord and the bidirectional flow of blood in spinal cord vasculature. This was a drawing. Now we can see really beautiful pictures about this vascularization. Here we have some veins and some radicular arteries, and in the posterior aspect of this spinal cord, we can see the posterior spinal artery. All the 40 spinal cords had Adamkiewicz artery. It was very common, this artery. 36 great anterior radiculomedular artery from the left side, 11 from left T9, and 8 from left T8. In this study, the average diameter of the artery of Adamkiewicz at the spinal cord was 0.81 millimeters, range from 0.6 to 1.11 millimeters. In 4 spinal cords, the great anterior radiculomedullary artery, Adamkiewicz artery, was in the right side. But 2 of these spinal cords, the Adamkiewicz artery was double, as you can see in this picture. One arising from left side and the other one from right side. Okay. This is an Adamkiewicz accessory artery. This is arising from lumbar nerves and Adamkiewicz artery, giving rise to a small thoracic artery and the Adamkiewicz artery. Okay, this is the thoracic artery was present in 38 spinal cords. 32 in the left side and 6 in the right side. 2 spinal cords did not have thoracic artery, most frequent in left T4, 9 specimens, followed by left T3 in 7 specimens. In 10 spinal cords, there were a double thoracic artery. The thoracic artery in the left photograph, in the left picture, the thoracic artery arises from right side. The thoracic arteries arising from left side in the right picture. The thoracic artery is the small caliber. A small thoracic artery. The narrowing of the thoracic segment of the anterior spinal artery has an average diameter of 0.33 millimeters, 0.17 millimeter to 0.53 millimeter. This measure was done at thoracic 5 level. This is the thoracic artery. The Adamkiewicz artery. No, this is not the Adamkiewicz artery. This is another artery that is very constant, the great posterior radiculomedullary artery. This posterior radiculomedullary artery was found in 28 spinal cords. This artery was found in the left side in 19 spinal cords. In 16 spinal cords was found in right side. In 7 spinal cords was found in both sides. This is a really beautiful artery. This posterior radiculomedullary artery is the opposite to the anterior great anterior radiculomedullary artery, Adamkiewicz artery. The posterior artery is coming from left T10. Various authors postulate such a vessel. Guillain in 1958, Lasortz in 1957, Romans in 1965, Jellinger in 1966. Others do not mention it or even deny its existence. Corbin, 1961, Clemens, 1966, and Domis in 1980. These authors deny the existence of this great posterior radiculomedullary artery. According to Jellinger, a large posterior radicular artery is in caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels. Diameter 350 and 500 micras. Its side is more caudal than that of the anterior radicularis magna artery. There is no doubt about its existence, and it's very important to know this artery. This is this picture. In this picture, we can see the great posterior radiculomedullary artery. In this case, is coming from left T9. This is the posterolateral aspect. In this spinal cord, even when there is not a great posterior radiculomedullary artery, there is a very good anastomotic arch, Adamkiewicz and the posterior spinal artery. Look at the conus medullaris. This is the conus medullaris, and the anastomotic arch is very nice. A right view of the anastomotic arch. The nerve roots have been displaced to the left side, and we can see the lateral aspect of this beautiful arch, anastomotic arch of the Adamkiewicz artery, giving rise to the posterior spinal artery. In this spinal cord, there was not a great posterior radiculomedullary artery. Instead, there were several radicular arteries giving rise to a posterior spinal artery. Left view of the anastomotic arch. Most of the arterial supply comes from the right side of the anastomotic arch. In this photograph, you are seeing the posterior aspect of the lumbosacral segment of a human spinal cord. You can see also a great posterior vein over the surface of the posterior aspect. Cervical radiculomedullary arteries. There were 24 cervical arteries.
इंटरनेशनल एक मीटिंग चल रहा है
Excuse me?
यमन में कॉन्फ्रेंस डायरेक्ट टेलीकास्ट होगा यमन से
Is there some problem, John Bennett?
Excuse me, Dr. Gupta, could you please mute yourself? Okay, I'm sorry. Go ahead, Victor.
Go ahead.
Okay, go ahead.
Okay. There were 24 cervical arteries coming from the right side, 8 from C6 and 8 from C7. There were 11 cervical arteries coming from the left side, 4 from C5 and 3 from C7. In 4 cord spine, there were 4 cervical arteries. In 5 cord spines, there were 3 cervical arteries. And in 8 cord spines, there were 2 cervical arteries. They are also really, really beautiful. These arteries are very important because in surgery of the resection of a disc, we should know where this artery is more common. The average diameter is 0.49 millimeters from 0.21 to 0.73 millimeters. Cervical artery. This is the smallest. This artery was the smallest. In 29 spinal cords, there were a great spinal anterior vein. We are told about the anterior vein. Average diameter 0.8 millimeters from 0.46 to 1.32. Look these pictures. It's really beautiful. The vein. We can see a great anterior vein. Beautiful, beautiful this picture. The vein and also the artery. These are the posterior veins. In 32 spinal cords, there were a great spinal posterior vein. Average diameter 0.86 millimeters from 0.52 to 1.48 millimeters. Look at this. This is the biggest, 1.48 millimeters, almost 1.5 millimeter. This is also a beautiful photograph about the veins of the spinal cord. Look at this. This is impressive. This is amazing. How the veins form like a wheel, covered by the arachnoid. only few spinal cords have this aspect. This is another shape of the veins. The smallest was this, 0.58 millimeters. Vein with some small curves. These are several shapes of these veins. So this is a vein that is crossing a nerve, a radicular nerve. As you can see in the upper part, the vein is between the fibers of this nerve. These are some interesting features in the veins. In the upper photograph, we can see the cervical posterior aspect. John Bennett, I want to show the video. Do I have some time?
Okay, we're going to wrap it up, Victor, in a few minutes, okay?
Okay, how many minutes do I have?
2 or 3 minutes.
2 or 3 minutes. Okay, let's go to show more photographs about the lateral aspect of this human spinal cord. Adamkiewicz also attempted to describe the venous network, which was subsequently characterized as complex and difficult to interpret. He also noted the variable density of microvasculature within the spinal cord. Now we are working, I am working, I am trying to describe more precisely the network of the veins of the human spinal cord. It's very, very interesting. So this is the last picture. I like to ask you if you have some questions about this. What I do to inject these spinal human cords is to get a fresh spinal cord and to inject with silicone the very, very small vessels to get this kind of injection. This is the last picture, John Bennett.
Okay.
Do you have some questions?
Yeah, let me ask Ishmael. Ishmael, do you have any questions from the audience that they would like to ask of Victor? Any questions?
John, just I have a small question myself.
Sure.
Okay, the lecture is very difficult actually. So, what is the main arterial supply for the spine? I mean, if we are going to make a surgery, what is the most important precautions regarding the intervention and avoiding of ischemic injuries?
Okay, I think that the most important feature in the spinal cord is to know if there is a good Adamkiewicz artery and also a posterior spinal artery. For example, if the vascular surgeon is going to clip an aneurysm of the thoracic aorta, if he has some accident with the Adamkiewicz artery, but this person has a good anastomotic arc in the conus medullaris with a very good spinal posterior artery, we are not going to have a ischemic process in this patient. So for that reason, it's very important to know if we have the anterior and the posterior radiculomedullary arteries.
Okay,
Very
second
good.
question.
Very good.
John, the second and last question. What is the best tool to diagnose the blood supply for the spinal cord? I mean, should we perform a routine CT angio, MR angio, or a conventional angiography before any surgical procedure?
Well, these arteries are very difficult to interpret in neuroradiological studies. It's not easy to find these arteries because it's very, very small. The posterior radicular artery is about 1.500 micras, half of a millimeter. So it's very difficult to see that in a radiological interventional studies.
Very good. Okay, Victor, thank you very much for an excellent presentation. Fantastic pictures. And we're gonna go to the next presentation with Deepak Gupta. He's a neurosurgeon from New Delhi. Are you ready, Deepak? How are you doing today? Can you hear me okay? Whoop, I can't hear you. You're on mute.
I just give
Okay,
me
Okay, there you go. How you doing today, Deepak?
I'm doing great. You have once again pulled me out of my vacations
Okay.
like last year.
Sorry about that.
But I'm very happy to be a part of it, and I'm very sorry that I could not be there personally to join this meeting, exciting meeting in Yemen. I need to share my screen, right?
Yes.
Okay.
Dr. Deepak.
Hi, Nasir. How are you?
Very fine, sir. How are you?
I'm great. I'm great. I was the only reason I said yes to this meeting was because I knew that one of our best resident from AIIMS, Dr. Nasir, will be here. So I'm very, very happy to see you, Nasir. Thank you very much.
Thank you very much, sir. We are very happy to be with us here in this conference. And I know Deepak, he is my personal friend, and he was my senior, and he's excellent in person and excellent in his profession. So please go ahead.
Okay. Is my screen visible to all of you?
Yes. Yes, we can see it. Fine.
Okay, perfect. All right. So I've been asked to talk about craniosynostosis. As always, I'll keep my talk very, very simple and very, very basic. I do not know the audience level out here. I believe most of them are neurosurgeons, and some of you do get to see patients of craniosynostosis in your practice to operate. Yeah. So I am presently a professor of neurosurgery and also the chairman of Pediatric Neurosurgery Fellowship Program at All India Institute of Medical Sciences, New Delhi in India. I do not have any disclosures, and because in craniosynostosis, I had to put a lot of pictures of these children. So I do have prior permission from the parents for display of pictures in this presentation. So craniosynostosis is defined basically as abnormal fusion of the sutures or a premature fusion of more than or one cranial suture. Now we must understand, when do we call it abnormal? The easy way to remember is that any sutural fusion, if you see in the first 2 years of life, that is abnormal, because by and large the first suture to fuse is the metopic suture, and it always begins after 2 years of age. So if you see any sutural fusion of any suture in the skull, before 2 years of age, then this is taken as abnormal. So in my talk, I'll be basically talking about scephocephaly and also about fronto-orbital advancements. These are the two things which I'll be covering in my talk. Now, children who present to us with craniosynostosis, they usually have, commonly they come to us with cosmetic disfigurement, abnormal head shapes, abnormal shape of the skull or of the face, or some abnormalities of the fingers and the toes in syndromic variants. They have got a restricted brain growth, and many of these patients on detailed evaluation, the neuropsychological evaluation and neurodevelopmental assessment, they are often, actually most of them are undiagnosed and missed in the majority. However, if you are diligent enough in examination of these patients and you've got trained professionals, you can actually pick up a lot of neuropsychological abnormalities in these children. Many of these children with syndromic variants, they present to us with headache and loss of vision. In fact, at times in undiagnosed or late presentations in syndromic craniosynostosis, they come to us with loss of vision, which is very sad. As you see out here, there are almost 22 bones of the skull, and there are 4 major bones which are united by 3 sutures. We have got the frontal bone, bilateral parietal bone, and the large occipital bone. Now, this is the thing which I always teach to all my residents. Please start to learn how to calculate the cephalic index, because this is one of the most commonest morphometric marker used in the clinical practice by surgeons all over the world. So cephalic index is calculated by dividing the maximum cranial width with the maximum anterior-posterior diameter or the cranial length. To put it in the simple word, in a clinical examination, you calculate the distance and about the tip of the pinna at the most widest point. This is the biparietal diameter, and this is the anterior-posterior diameter from the glabella to the most prominent part of the inion at the back of the head. So you take these parameters divided by and multiply by 100. Normal range is 79 to 81. Any cephalic index, if it is less than 75, it favors a diagnosis of scephocephaly. And if the cephalic index is more than 80, in fact it's above 82, then we call it brachycephaly. Now, scephocephaly or the sagittal suture fusion is the simplest and the commonest type. It is seen in more than 50% of the cases, I would say. Males have got a very, very high preponderance. Almost 5 times incidence is seen in the males as compared to the females. The classical scephocephaly is fusion of one suture, that is a sagittal suture, which is a midline suture. Almost 10% of these cases are atypical, wherein you have got fusion of not only the sagittal suture, but also the coronal or the metopic sutures as associated feature. Now, majority of the children, they come to us for cosmesis, that they say that the head is large, oblong, or the boat-shaped head, and they come for a cosmetic surgery to a surgeon. And of course, this cranial deformation can also have major psychological impact on the children. When the children are in the school, their schoolmates may complain and may say that, oh, you are born with some abnormal head and all that. And they commonly bring it to the notice of their parents, which often comes to their attention, and they come to us for evaluation and further treatment. Abnormal high intracranial pressure is not uncommon in scephocephaly, especially in the atypical variants. And 10% of these cases of sagittal sutural fusion, they have got coexistent intracranial pathologies. Role of preservation of surgery in preservation of cognitive skills is not relevant in majority of the cases, I would say. This is how the atypical scephocephaly actually look like. In the interest of time, I will run over it. Now, you talk about the neuroimaging. There have been a lot of controversies and debates and on what investigation to do to avoid CT scan in these patients because of ALARA guidelines. But by and large, majority of the surgeons in most part of the world, they do end up getting the high resolution or the 3-dimensional NCCT head of these children, of course, in the low dose protocol. So you can have the plain X-ray of the skull wherein you can pick up this sutural fusion, and the CT gives you a lot of information in these patients. I always get NCCT with 3D reconstruction of all my children, and along with that, I always do MRI of the brain and with MR venogram, because it tells me lots of additional information, the presence and absence of hydrocephalus, the herniation or the presence of Chiari, because in case a patient of craniosynostosis has got a Chiari malformation, this makes me change my plan completely. I have to do more of a occipital distraction or a posterior fossa enlargement in these cases rather than approaching this patient from the front. So, and of course, the MR venogram tells us about the abnormal veins and the bone cuts which I have to make, and to prevent any inadvertent sinus injury or the venous lakes injury in these patients. So it remains, I would say the CT scan remains unquestionable because it gives a lot of diagnostic information, and additional intracranial pathologies are actually picked up on CT scan in these children. Now, these are the abnormalities you can see in these patients of scaphocephaly. You can have frontal bossing, bitemporal depression, pinching, prominent sagittal ridge, occipital bossing. And this presentation, I can share it with you and your residents can see it later. So I will skip it in the interest of time. And so these are the twin cases. Both of these children were born on the same day by cesarean section. They came from south of India to me, and it was a parent's request because the kids are born on the same day. We want them to be operated on the same day. So it was a big challenge for me because an average surgery takes to me almost 4 to 6 hours per patient. Anyhow, and they had a rare blood group that is AB negative. So I took up these challenges, and one of the child had got classical scaphocephaly, and other child had got atypical scaphocephaly, wherein the coronal suture was also fused. So these are the CT scan of these children. You can see in one child, not only the sagittal suture is fused, but also the coronal suture is also fused. However, if you look at this child, the sutures are patent. You can see the coronal suture is patent, and the back cut, the lambdoid suture is also patent. Only the sagittal suture from the front to back is completely fused. So this was classical scaphocephaly, and the second child was atypical scaphocephaly. So this is the beauty of nature. You can see both the variants in the twins together. So this is what I did. I did cranial vault remodeling and advancement in both these children, and they were 1 year of age when they were operated. In fact, a week after the surgery was their birthday. And the intracranial pressure, interestingly, was high in one of the child of 22, that is atypical scaphocephaly patient. So these are the bone cuts, and we have to do a lot of play around with the bones to give them the correct shape at the end of the surgery. I'll just quickly show you a video of these children. And so this is how the child was looking like before the SPECT was suggestive of hypoperfusion. And this is the pericranium flap being raised and the bony cuts being marked in this patient. And then I do intracranial pressure monitoring in my patient to see what is the pressure before opening the skull. And you can see the pressure was on the higher side, 24 in this child. Subsequently, the bony cuts are made as per your preoperative planning. And now the skull, the bones are out, and then outside you can reshape the bones with the shape you have decided before the surgery for the children.
So I made multiple barrel step incisions both in the front and all around the bone, and this is the original shape. So by this, now you can
give green stick fracture and expand the frontal bone to your liking to fit in the best shape to this children.
Looks much better now. See?
And this is the midline sagittal ridge which was removed.
I would like to break it.
And this is how the child looks like before and after the surgery. And both the childs look exactly like each other. After the surgery, the parents were pretty happy after the surgery. You can see the large head before and the nice head shape after the surgery. All right. So basically, I would say that in scaphocephaly, one needs to distinguish between sticky sutures and the sutural fusion, which can be easily done based on the CT scan or the X-ray imaging. Atypical scaphos, they require tailored treatment and the follow-ups. The cephalic index is something which is recommended for all patients, should be done as a baseline. And the preoperative 3D CT with Recon with surface rendering is very, very useful. And I often feed in these images in my obstetrics, and I plan out the surgical procedure beforehand. And earlier the better. I most often operate these patients at the age of more than 6 months of age. And of course, most of these children, they require prolonged follow-up. The second thing I want to cover in my brief talk is about the forehead advancement, because we must understand all these patients of especially the plagiocephalus and the syndromic variants, they require some kind of a forehead and a frontoorbital advancement. So this advancement basically consists of two parts. The inferior part is the supraorbital rim. This is the supraorbital rim, and the superior part is the frontoorbital forehead up to the coronal suture. And if you talk about the supraorbital rim, this is also called as bandeau by some surgeons, and it consists of supraorbital rim and part of the orbital roof and the lateral orbital wall. So this whole construct is called as the frontoorbital bandeau. So when we say, we always do frontoorbital advancement and reshaping of the anterior 2/3 of the skull ahead or just behind the coronal suture. But for doing this, absolute knowledge of 3D plane is very, very important to the surgeon, because the basic concept in the deformity correction of this patient is you have to do deformity correction in 3 planes: anterior, posterior, superior, inferior, and side to side. And you can see out here, before the surgery, I usually make my 3D STL models of these children, and I plan out before the surgery what are the cuts I have to give in the frontoorbital bandeau to give a nice shape, because at the end, whatever the shape you will give to this frontoorbital bandeau, the same shape will be taken by the forehead and by the growing head of the child. So these are the level of cuts, and this is the advancement I have done in the side-to-side plane and in the front projection. You can see I've given a lot of space in the front. So by giving this space, the unrestricted growth of the brain, which is maximum in the first 2 years of life, is allowed to the patient and giving a good outcome to these patients, apart from the cosmetic outcome itself. You can see this child with a grossly deformed plagiocephaly. You can see before the surgery and after the surgery, a nice contour of the head is being given to the child. This is another child, 18 months old child, came to me from Dubai, and you can see this child had a nice contour. And if I do a 3-month post-operative CT for my children, and you can see there's a nice space I've created, and almost 1.5 centimeter advancement I've done in the lateral, and almost 1 centimeter advancement I've done in the frontal projection also to this child. And this child now has got a 1.5 year follow-up, and he's doing absolutely fine. This is another child, and you can see I do the planning, I do marking of my cuts, where exactly the frontal eminence I want before the surgery, by doing my photometry and Photoshop before the surgery, and I decide what is the shape I'm going to give to my child at the end of the surgery. So I superimpose the patient's clinical image and the soft tissue image, and I do photomorphing, and I do my photo cuts planning before the surgery. What are the level of cuts in the frontoorbital bandeau I have to give the right shape to the surgery. So I go to the theater with a preoperative planning, and you can see this child with a very severe brachycephaly. The head is almost flat, in fact sunken inside, with a marked coronal synostosis. And this is how the child looks like 2 months post-operatively, and it's a very decent outcome we have got on this child. So these are a couple of other cases, and sometimes we have to rotate the 180 degrees rotation of the entire forehead, front back, to fit in the contour after doing the advancement of the frontoorbital bandeau. So knowing this thing is very, very important for most of the surgeons for giving a good outcome. This is another child, you can see, with a metopic craniosynostosis. I had to do a frontoorbital advancement and reshaping of the frontal bandeau. So what is the best time to do? There have been many publications from the Necker group in the Paris and from other parts of the world. It has been seen the incidence of raised intracranial pressure is high after 1 year of age, and in syndromic variants. You can see out here in brachycephaly and complex craniosynostosis, the incidence of raised intracranial pressure is up to the tune of 30 to 47%. And of course, the better mental outcome is also noted in children of Epert's if you do surgery less than 1 year of age. So my personal recommendation is the best time to operate these children is after 6 months of age. They become fit for anesthesia, the bones become pliable, they can be molded, and the child tolerates the surgical procedure well, and there is no added damage to the child by delaying the surgery further. So for me, the best time I would say is 6 to 12 months of age. If any child comes to me before 6 months of age, I prefer to do just plain suturectomy, either by the open procedure or by the endoscopic procedure. But then you have to add it on with some helmet therapy to these children. But if the child comes to you after 6 months of age, which is the setting in most of the patients coming to me in my country, in India, so therein I usually do a frontoorbital advancement with anterior 2/3 cranial wall remodeling in most of my cases. This is another video of a child wherein a child was 18 months of age and who had bilateral coronal and sagittal craniosynostosis. And you can see this child before the surgery. And then you can see out here, I do my marking intraoperatively, where exactly I have to do my frontal eminence on right side, left side.
There should be symmetry on both the sides. So the distance from here to there is approximately 5.
So I take out this mid part of the frontal bone to bring it together, and of course this height needs to be
I'll
restored.
check it's symmetric on either side, but I'll try to keep a margin
So this is called as a geometric or a mathematical correction of craniosynostosis. You can see all these cuts which we are making is after thorough preoperative planning in these children. So it involves a lot of mathematics and surgical skills if you are really aiming for a good cosmetic outcome to your children. So the bones are being elevated under vision, and of course you need to avoid hypothermia and blood loss in these children. And you can see this is the bone being reshaped, and we can put it these absorbable plates either on the inside or the outside, and this is how the planning is done. And this is the advancement being done. You can see these absorbable plates being used, and see the head looks pretty decent, I would say, no? Yeah. And this is how the child looks like after the surgery. So most of the patients of syndromic and some of the patients of non-syndromic, especially plagio, trago, oxycephaly, they need a frontoorbital advancement. And these are the few syndromic variants of Epworth's marked Cruzon. In fact, this girl came to me at the age of 15 years, and I did just a frontoorbital advancement and some amount of CVR in this patient, and now she's waiting for mid-phase distraction for taking care of the process further. This is another child with significant Epworth's, and we operate. This is another girl with Epworth's, and this is another girl with the Cruzon syndrome. This is a child with the Cis-Jordan syndrome, which we operated recently. And these are the collection of patients which I have done. And there is a lot of controversy regarding the supraorbital supratrochlear nerve. However, I would say that in children less than 1 year of age, you can safely get away by damaging. I don't say that you should not make an attempt to save it. You should attempt to save it. However, if in patients when there is an atypical transaction of supraorbital or supratrochlear nerve, it is usually fully compensated in these children. The most important thing I would say is that I've started avoiding putting any fish hook retractor in these children, because these children have got narrow airways. The tube size usually goes is around 2.5, 3 or 3.5. And when the anesthetist, when you do some amount of flexion with this fish hook retractor, the tube can get kinked further, leading to rise in the EtCO2 in these patients, and patients can have intraoperative bradycardia and in fact cardiac arrest also with excessive neck flexion in these children. So you should keep a strong watch on the PCO2, maintain the temperature of these children, avoid significant blood loss, keep a watch on the sponge count in these children, because these are the things which are very, very important, and you learn from your mistakes. We do on an average 10 to 15 cases of craniosynostosis at All India Institute of Medical Sciences. The most common complication I would say is the blood loss and the hypothermia, which one needs to avoid. And of course, there are a lot of training modules. I do my training of my residents and my fellows on 3D STL model. You can make these models. This is a polygalactin PG and PLA models which can be made before the surgery, and you can practice and
Okay, a little interruption there. Can you hear me, Deepak?
And then that's going running in this, because the moment to keep minimum. And of course, the cosmetic and the functional results are better with the early surgery and surgery in infants as compared to surgery in the older children, I would say. I would like to thank my nursing staff, my teachers, Professor Mahapatra, who is my mentor, and of course my patients and the parents who showed confidence in me to give their children in my hands to operate. I just want to bring it to notice of all the surgeons who are listening to me that at All India Institute of Medical Sciences, we have started 1 year pediatric neurosurgery fellowship course, and it's a course for 1 year. The seats are open in the month of February and August. The web link is www.aims.edu, and anybody can apply for this course, or they can write directly to me at my email ID, drdipakgupta@gmail.com, for undergoing fellowship in pediatric neurosurgery training at our institutes. We do almost, I would say, 1,000 children per year out of 5,000 operations that we do at our institute. And I also take this opportunity to invite surgeons to AIMS Neurotrauma Conference. We will have a AO Neuro course also just prior. This will be between 26th to 29th of October at All India Institute of Medical Sciences, New Delhi, India. Thank you very much.
Thank you very much, Deepak. I'm sure the Yemeni neurosurgical community really appreciates you taking time from your vacation to give such a great presentation. Okay, we have a couple of minutes for questions. Ishmael,
7 minutes.
do you want to run that, please?
Do you have any questions? Okay, one question. There is one question, Dr. Deepak. Stay with us
Yes,
on
Nasir.
the.
A very simple question. Do you think that the age plays a role? I mean, do you have any age limit for the procedure performance? The maximum
Before
age?
for- Yeah, so in patients with pure scephocephaly, which is very, very common, you should do suturectomy as early as possible. I would say suturectomy endoscopic procedures have the best results if done before 4 to 5 months of age. This is about the non-syndromic variants. However, if you're talking about the syndromic variants, my personal take is the best age to operate these children is at the age of 9 months of age. People recommend after 6 months, but after 9 months, so between 9 to 12 months is the best time to operate the syndromic variants. But if you just want to do plain suturectomy, the best age is before 6 months of age.
Okay, thank you. Thank you.
Okay, thank you very much, Dr. Deepak sir.
And Nasir, you should come to India. You have not come to India ever since you left us. Which was the year you were with us in
No.
2006?
I'm coming frequently to India. Almost every 3 months I have come 2-3 times to meet you there in All India Institute of Medical Science, but I couldn't meet you, unfortunately.
Oh my God.
But
Oh my
hopefully I'll meet.
Okay.
Thank you very
okay.
much, sir.
Thank you
Thank
very
you,
much.
sir.
And Nasir, I'm very happy to see you. If there are any other questions from the panel, I'll be very happy to take.
Okay, thank you very much, sir.
Okay, Victor, do you have any questions? Or Mauro? Or
Congratulations, Dr. Deepak. Your kind of surgeries is really amazing. I hope to see you next year in Nueva Delhi. Greetings from Mexico City.
Welcome. Thank you.
thank you.
Gracias.
You have
No question.
any more questions?
No
Okay.
more
Question.
questions.
Okay,
Go
Deepak,
ahead
thank
with-
you. Thank you very
Thank
much.
you very much. Thank you. Thank you. Thank you very much, John. Bye-bye.
Okay, we'll have it edited and we'll send it to you.
Sure. Bye-bye.
Thank
Have
you.
a good day.
Bye-bye.
Bye.
Okay, very good. Okay, we have a few minutes here. Greetings, Mauro. The next speaker, Mauro Seguro, is a neurosurgeon from Morelos, Mexico. Hello, Mauro.
Thank you, John. Thank you for the organization.
Okay.
Maybe I have a few minutes, John, to arrange my presentation online.
Okay. I guess we can start, Mauro. Do you remember how to screen share on the PowerPoint? Well, we can lead you through it if you don't.
Not really. Maybe Victor. Could you
Okay,
please
well,
help me?
I can sí, Victor, tú puedes explicar a Mauro cómo compartir la pantalla, por favor.
Sí, Mauro, mira, tienes que ir a la izquierda de tu pantalla y hay una flechita blanca dentro de un cuadro verde. Ahí le pones, ahí le activas, le pones ese y una vez que entras a esa flecha, activas en tu pantalla, en tu panel, pones ahí tu presentación y le das ya Enter para que se vea toda la pantalla.
Sí, ya lo hice.
Ahí estás en Hangout, en tu pantalla del lado izquierdo, en la parte superior aparece un cuadrito verde con una flecha blanca. Ese es para compartir. Luego aparece un icono donde dice compartir, le pones compartir. Le das un clic en compartir y ya aparece tu pantalla.
Si le estoy poniendo, dice Screen Share, le doy.
Sí, ahí en Screen Share, dale.
Se inició la cámara, el foco verde,
No,
pero no me aparece mi escritorio. ¿Me regreso?
sí. Vete a donde está Hangout, donde estabas en Hangout. Y del lado izquierdo tienes una pantallita, tienes un cuadro verde con una flecha blanca adentro. Ahí le das clic. Una vez que le das clic, ahí aparece en tu pantalla una parte que dice compartir. Ya que viene compartir, ya compartes. ¿Sí?
Okay.
Y te vas a tu plática. Una vez que le apretaste esa pantallita verde, te vas a tu plática y la abres. Y ya le das ahí enter y ya va a aparecer tu plática.
Dice empezar a compartir mi presentación.
Esa, ahí dale a empezar a compartir.
Sí, pero esa no es mía, esa es de alguien más. Eso. Esa no es mía. Aquí, ¿ustedes ven algo infinito?
No, pues sí se ve como el infinito ahí.
Esto es un problema de algo, porque yo no estoy haciendo eso.
Sí, ¿por qué no te vas, Mauro, primero a tu pantalla y pones tu plática? Pones tu plática, la abres. ¿Sale? Ya una vez que ya abriste tu plática, la tienes tú en tu pantalla ya abierta. Ok, ábrela en tu pantalla. Ok, ya. Ahora regresa a Hangout. Déjala abierta y regresa a Hangout. Una vez que regreses a Hangout, donde aparece del lado izquierdo en tu pantalla, del lado verde, le aplicas ahí el verde y le pones compartir y regresas otra vez a tu pantalla y le das enter a tu plática.
Sí, lo hago, pero a la hora que dice escritorio, ya no aparece mi plática. Aparece esta cosa del infinito.
Ah, no, entonces no sé qué problema estés teniendo.
Ok, ¿quiere mandarme su PowerPoint, Mauro? Yo puedo compartirlo. Mándame por email. Mándame por email, por favor.
¿By Facebook?
Por email. O Facebook está bien. Si tú puedes mandar por Facebook está bien. ¿Tú puedes? ¿Sí o no?
Yes, I'm doing. Okay, maybe the problem that my presentation is right now online, so I'm going to close and then come back.
Okay, tú es casi ya. Tú es casi. Sí, eso es. Cambia slides. Let's see you change the slide now. Okay, your presentation is there now, I think. Yeah, that's it. There you go. Okay, now you just need to, yes, we can see it, and now you can change the slide. Yeah, you can start now. That you were on the presentation. Okay, there you are. There you are. Okay, when you want to change. Whoop, you fell off again. There you are. When you want to change the slide, you click on the left side.
Okay, let me find out.
Okay, there. You click on the left side, the slide on the left column. See the left column?
Yeah, but what's happening with that?
Yeah, send me the PowerPoint, Mauro. Okay, I'll do it. Don't worry about it. We'll get it. Please send me the PowerPoint. I'll do it. That's the problem with busy neurosurgeons. I wanted to orient you this, but you were too busy. Could you please send me the PowerPoint?
John Bennett email.
Yeah, I'm gonna give you my email address by Facebook.
I have.
Okay, and then you email me your presentation.
Okay, I will send him.
Okay, there's my email address.
Yes.
Please
You
email
have?
me your PowerPoint, and I'll.
Yeah, I did.
Okay. Let me check. Don't have it yet.
Yeah, maybe because it's heavy. Ah. Mm. Did you receive, John?
No, I haven't received it yet. desertedbeach@hotmail.com. It should be in your Facebook.
Yeah, we have 41 megabytes. And it's right now it's moving out. I'm sorry.
Did you email it to me?
Yes, I did.
Well, I'm not getting it. Can you send it by Facebook?
Okay.
Si repites el paso, Mauro, ¿estás intentando enviarla por Facebook?
Bueno, ahorita la mandé por email. Voy a mandarla por Face.
Porque puedes intentar otra vez. Mira, a lo mejor es diferente, pero lo que yo hago es abrir mi plática como si ya la fuera a dar así. Y luego me voy otra vez a Hangout, me voy al lado izquierdo donde está esa pantallita verde con una flecha blanca, le aplico ahí, le doy un clic y dice compartir. En ese momento le doy a compartir y me voy otra vez a donde tengo mi plática y ya la pongo en la pantalla en grande, le doy a Enter para que se empiecen a ver las diapositivas. Pero no te da, ¿verdad?
Y como ya la envié, ya se me está
Ya lo hizo
calculando.
antes, doctor. Lo que pasa es que no tiene que regresarse a Hangout. Cuando ya logró compartir la presentación, se regresa a Hangout y se va a volver como hace rato, como que al infinito. No tiene que regresar a Hangout. Lo comparte y ya inicia la presentación. No regresa otra vez.
Ok, pero ahí te lo acabo de anexar por Facebook, John.
To Monday por Facebook, ok, déjame chequear. Ok, no recibe por Facebook. Mi dirección de email está en su cuenta de Facebook para mandar su PowerPoint. ¿Puede mandar así? Tú puedes ver mi dirección de email, ¿verdad?
Yes, I did.
Ok, manda este email.
Yeah, I already sent it by.
¿Sí?
It's too heavy.
Déjame chequear. ¿Es demasiado grande?
Sí. Entonces,
Okay, entonces. Okay.
Intente, doctor. Otra vez intente.
Okay, sigue,
Okay.
sigue tratando compartir. Entonces, I'm sorry, Mohammed.
Yes.
With the busy neurosurgeons, it's tough to get them to learn this platform. So it's the nature of the game of neurosurgery. They're busy guys.
Okay.
Okay. Do you want to try again, Mauro? Okay, you basically
Yeah.
leave the Hangout and open your PowerPoint. You were very close to having it before. Leave the Hangout, minimize it, and open your PowerPoint. Okay.
Can you see something right now? No?
No, not yet. Not yet. You need to get away from the Hangout. In other words, you won't see me. Minimize it. You're using Windows or Apple?
Apple.
Okay. Minimize the Hangout and open your PowerPoint and leave it on your computer. Leave it and then come back to the Hangout. And tell me when you're back
Okay.
at the Hangout.
Abro.
Okay, you open the PowerPoint, right? You open the PowerPoint. Is the PowerPoint open?
It's open. I know.
Okay, now go back to the Hangout. Open the Hangout again. Okay, and then click on the green arrow. On the left side of the menu, there's a green arrow on the screen share. Click on that. You see the menu on the side of your screen? Do you see that at all or no?
Lleva tu
Yes,
cursor del lado izquierdo de la pantalla y ahí apriétale la pantallita verde que dice compartir.
Sí, sí lo hago, pero es cuando
A
me
ver.
bota al infinito.
A ver, dale otra vez.
Ok. Ahí deben de verla. ¿La
Okay,
pueden ver?
okay. Now you're getting there. Okay, now, okay, yeah, you're there now. You're there now.
Ahí se ve.
Okay. Okay, now start on the first slide. You're good. It's good. There. Good. Good.
Yo no los veo.
Yes.
no importa.
Okay. You're perfect. Don't leave it. Don't leave it. You're perfect. Okay. You ready to start, Mauro? Okay. You ready to start?
Ok, voy a hablar. ¿Ustedes me ven? Ahí está la presentación, doctor Víctor.
En
Sí, se
inglés,
ve
por
bien
favor. En inglés, Mauro.
So, I have like 20 minutes.
Can you speak English? Can you give the presentation in English?
He's ready.
Yeah, please.
Mauro.
Okay. Hello to everybody. Thanks. John Bennett, I'm professor from Yemen. I'm very happy to participate. Can I ask to somebody who is with a dog?
Yeah, who has the dog in the background? Victor, do you have a dog in the background?
Okay, let me see.
Yeah, please silence the dog.
That's
Okay, thank you, Victor. Thank you. Okay, Mauro.
Yeah. Good evening from Mexico. From right now, it's 1 a.m. in Mexico City, so I'm very glad to participate in this international meeting from Yemen, neurosurgery. So I would like to introduce myself first. My name is Mauro Segura, and I did my basic studies in the National University in Mexico. I'm my postgrad from the General Hospital of Mexico, besides from many other professors, including Dr. Victor Perez. And besides that, I spent a couple of years in Japan with Professor Kawase and many other people. And from the time to time, I start to geminal nerve, and that's why the reason from this presentation. From the last 15 years, I have been working on this cerebellopontine angle. So I will introduce my experience in the last 15 years, and from this experience I took about 10-12 cases from epidermal cyst tumor. So my hospital is called Hospital Angeles from Morelia City in Mexico. And I know that there are many neurosurgeons, but this is for the student. The epidermal cyst tumor is actually a embryonic tumor derived from the remaining element from the ectoderma. So from this destroy and the cluster of the neural tooth between third and the fifth week of the gestation. We all know that. However, we don't know exactly in Latin America, or at least in Mexico, we have about 1% from all intracranial tumor and about 7% of the cerebellopontine angle tumor. So we are talking a very, very specific and selective tumor. What does it mean? That there is a few experience, or at least a few accumulated experience for this topic. Most of them is growing from the third and fifth decade of the life. And about the classification is another topic, but we know the histopathological classification. It's very important to clear that we are talking about a benign tumor, not malignant, but benign. So in the case that we remove totally, we are providing a cure. So that is important in our topic as brain surgeon. However, from the last decade, it has been many failed therapeutic, like failed surgery or some kind of chemotherapy. It has don't work. I'm sorry. About the diagnosis, it's very easy, and I would like to present this table. From the last 7 years, we have a cumulative experience from 370 cases, operated cases of trigeminal neuralgia syndrome. So this is the most important point. Most of the patients come to us with facial pain, and we don't know what's happened inside. Besides that, we have to make a clinical recognition, exploration, interrogation, and the most important is always to do and review face-to-face with the radiologist the MRI, especially the 3D volumetric sequence. And most of you, of course, you know, the most important is to find and not find a tumor brain. Epidermoid cyst or another, like meningioma, chordoma, neurinoma, some kind of metastasis or some kind of carcinoma. And it could be another type of tumor. Once we review the MRI and once we do a careful analysis of the MRI, we can easily establish the diagnosis. It's trigeminal neuralgia as pure syndrome, or it could be one of these 8% cases. In our experience, about 370 cases, 8 to 10% represent brain tumors, as we can see in this table on the right, including all these type. However, about 10 cases, we do some 1 or 2 cases. We have half of them represent epidermoid cyst. In the next table, we can see we are working for the last 15 years in we call telemed with collaboration with the US. Most of our patients came from Mexico, but however, another came from another Latin American countries. No one for Yemen, of course. And this is our general distribution by age. We can see by decade, 10, 20, 30, 40, etc. There is a peak. We observe the peak is similar to another publication from 40 to 60. It's very common. Some of our patients are more than 70 years old. It represents 16% of the cases. I will back. There is no difference between woman and male. I want to present this table. We prepare, and it's actually in revision. I would like to validate with another neurosurgeon or with another institution, because we divide the course of the trigeminal neuralgia in 3 phases: 1, 2, 3, or initial, medial, and advanced, or pharmacological phase. Non-pharmacological phase, the patient is coming with help in this phase, and finally, advanced phase. This is the most complex phase, and this is the time with the neurosurgeon have to spend more time trying to find a solution, because most of the patients have some kind of surgery, complex cases, complicated cases, and so. And you can see in this cake table more approximate distribution. Half of our patient coming in the first phase, a quarter or 25% of patients in the medial phase, and 17% of patients in the advanced phase. So what's important in this point, that not all the patients have the same etiology, not all the patients have the same phase, not all the patients have the same grade or intensity of pain, but the most important I want to underline is all patients with the simple fascial pain is coming with all for help. We are obligated to do an MRI in Mexico. It's easy to perform this kind of study. But the most important is that we have to share information, and we have to exchange information and imagine with the radiologists. So we are going to find very important data. And the most important for this presentation is we can easily understand what is the cases of epidermoid cyst. As you know, T1, T2 is hyper density. It's not a matter of this presentation. I would like to show this. I hope you can see the video. This is a typical finding of the MRI, and you can see I'm surrounded with my pointer. This is a typical imaging from the epidermoid cyst. In this case, in the left cerebellopontine angula. So I want to repeat. For an experimented eye, it's very easy to understand that this is an anomalous position of the in this case, tumor, and you can see the tumor is moving or displacing the brain stem. It's not infiltrating. It's not infiltrating bone. It's not infiltrating dura. It's just surrounding around the brainstem and, of course, cerebellum. In some cases, We have a couple of them. It's a GN tumor. I presented this kind of tumor, more than 15 centimeters, in Japan 10 years ago, and it was very incredible to find this size. That happened. That thing happened in Mexico. I would like to introduce another example. Well, you can see this is another case, but it's very similar.
For whatever data they want.
Okay. You can see it's a little bit small. This is a little bit smaller. Also, it's located at the left cerebellopontine angle.
In terms of specifications, I just mentioned that
You can see. Of course, beside that, we can try to find the trigeminal nerve. It's not visible. I will relate. Well, this young lady was a very typical facial pain. This is an operating room. For us, it's very important to use the most technology as possible. And please watch this video from the microscope. This is the characteristical tumor, like a pear. The ribs and the French people describe like a pear tumor perlado. Y at the finish of the extirpation, we observe the cranial nerve. The patient immediately after the surgery. Another case, the second MRI I showed.
I'm online.
Also, this is the characteristical structure from the wide, soft, easy to aspirate, and this is different than the people imagine. This is not a pseudomembrane. We are analyzed by histopathological, and this is the arachnoid with some kind of inflammation, just arachnoiditis. And the tumor is inside of the arachnoid, and it's very easy to aspirate and manipulate with bipolar, CUSA, some cases, or simply aspiration of Frazier. So I would like to advance. You can see it's only piece to remove up to the bottom. You can see in the bottom, and we can clean completely the structure around surrounding the vascular arteries. Some remand. In some cases, we can use the endoscope. Actually, it's very dangerous. I prefer don't use the endoscope unless it will be very necessary. Some kind of hemostatic jet fan. And finally, the last portion of the tumor in the bottom, and the pseudo capsula, like it's actually the arachnoid. At this point, we can be very careful because the small bases, and of course, you know, we can be very careful with the hemostasis. So there is no problem, at least for the last 15 years, we are follow this patient. I will inform you at the last of the presentation what happened with this patient. Maybe, how many minutes left? John, please.
I'm sorry, Mauro.
How many minutes do I have?
We're almost done, Mauro. If you want to, why don't we wrap it up and let's open it up for questions.
Okay, okay. I will advance this. Okay, that is the end of the operation space. Everything is clean, small arterioles, the basilar artery, and like that we have 12 cases. I'm sorry. So we put in. So I have to insist that the main important is to have a clear and defined diagnosis before the surgery. This is the early aspect of the tumor, as you can see. The second point, in my opinion, is to have the all technology available for this case, including microscope and endoscopy, anesthesiologist, the machine, aspiration, CUSA, etc. If you don't have all this, we don't recommend this surgery. At the bottom, you can see the typical imaging. This is not a so huge tumor, but it's somehow. And, well, the history to see how I do. The patient is the third recommendation. We have to do this surgery with many careful, with many patients, and with all time is necessary for each patient. And at the end, we are going to find some good result. Not always, but another case is important because in this case, this patient have trigeminal neuralgia from right side, and 1 year later, epidermal cyst was found. This is the case. Bilateral trigeminal neuralgia, compressive case associated with the epidermal cyst. So, and again, also, I will to accelerate, obvious for the time, but you can see the brain stem, you can see the trigeminal nerve. And this is vasa nervorum. Sometimes it's possible to sacrifice. And then we can see the trigeminal nerve root absolutely clean. So, well, I see most of the patients have a compressive trigeminal neuralgia. However, about, in this case was 10 cases, actually is 12 cases caused by epidermal cyst. This is just a preliminary review. Some kinds of complications like CF 1.45, keratitis by trigeminal lesion of the ophthalmical branch, facial loss of the audition. Up to now, there is no case derived from the surgery. However, I would like to okay. Okay. Well, I would like to to say some preliminary conclusion. Is, of course, this is just a few cases, but I'm sure that we are doing some follow-up. In the beginning, before this register, we have 2 death cases because of the vasospasm, and the other was because of bleeding. So, in the last 10 years, I prefer not total removing from the tumor. It's better for us to leave some kind of tumor, some remnant tumor. We know this is a benign tumor, and from long time it could remove. However, it's better to do a second or maybe a third operation in order to preserve the life and preserve the cranial nerve integrity, beside to put in risk the life of the patient. That is the lesson learned from the last 10 years. So this is the end of my presentation. Well, I apologize for the delayed introduce, but I would like to know any question. Thank you very much.
Okay, Mauro, thank you very much. Thanks for taking the time. I know it's late in Mexico City, and this is a new technology, but we'll both learn it better. Any comments or questions, Ismail, from the audience before Mauro goes to bed?
Any questions for the audience? Okay, I have one question from my side. What's your recurrent rate in epidermoid surgery? Do you have a recurrence rate, and what is the is it early or is it late?
Yeah, from those 12 cases, 2 patients died, and the last other 10, I have 1 recurrence at 3 years. Another patient has been operated in the last 3-4 years, so we are waiting. What about that? Maybe will be some recurrence. I don't know exactly when and how frequency will be.
Okay, very good. Well, thank you very much, Mauro, and we look forward to your next presentation. Okay, we're going to move on to the next presenter. And Mauro, we hope you hang around for this if you can, or if not, I know it's late. We have Dr. Chan Deopujari. He's a very big neurosurgeon from India. He's the first doctor I've seen that's done so many fellowships. First neurosurgeon I've seen fellowships in Toronto, in Miami, in Germany. And welcome, Chan. How are you today?
I'm good, thanks. I hope we remain connected for some time to get this talk done.
Yes.
So, is everybody comfortable there?
Yes, everything's good. Okay, we're ready to start.
Okay.
Okay. You want to begin your talk?
Yes. Shall I go on the screen with the talk?
Sure. Could you please say a few words about yourself, Chan? You have such an impressive history.
I'll work myself. Okay. Can you hear me?
Okay.
Yes, we can.
Yeah, you can go ahead. You can go ahead.
Okay. So thanks for this opportunity to talk to you guys. I'm going to talk about something very basic, ETV for hydrocephalus, and talk about some of the ways how the procedure developed, the current indications, and some of the things you may be interested about the outcome and what's the future of this kind of treatment. ETV has become very popular and probably is thought of the first procedure to do for hydrocephalus by many of us today. But it has been a long journey, and this is probably the first endoscope ever made, which is kept in a museum in Vienna. There's a very nice endoscopy museum done, and anybody who visits Vienna, I would strongly recommend to go and get a sense of medical history there. And then I think many of you are aware that it was only choroid plexus fulguration to begin with, and actually the first incidence of a third ventriculostomy done by a percutaneous approach was in 1983 with some endoscopic vision by Mixter. First kind of a series was presented by Putnam in 1943 with 23 patients with about 4 deaths during that. Radiological control was used to perform this procedure by a couple of these guys in 40s and 50s. And of course, with the development of the shunt in 50s and 60s, there was virtually no place left for the endoscopic surgery for hydrocephalus. One of the main reasons was probably that the visualization scopes were not so good, and it is only after the Hopkins rod lens system developed in 70s that the interest was renewed. And today we have something like a standard procedure for performing an endoscopic third ventriculostomy through a pre-coronal burr hole, looking at the third ventricular floor through the dilated foramen of Monro in a case of obstructive hydrocephalus, and then we go ahead and open up the third ventricular floor by various ways. And people have used leucotomes, puncturing needles. People have used Fogarty balloons way back in 90s, forceps, monopolar wire, double balloons popularized by the French group, and Dormia basket is used by one of my colleagues in Taiwan, which is usually used to take out the ureteric stone. So which cases actually go for third ventriculostomy? And I think the favorable radiological features probably will tell you that there is a clear evidence of ventricular non-communication and obstructive pattern of hydrocephalus, aqueductal anatomical obstruction, and or lack of aqueductal flow void on T2 weighted MRI. And in an ideal world, this should be your sort of criteria to decide if the patient deserves a third ventriculostomy or not. But in the developing world, it may not always be possible, but the minimum requirement in a patient radiologically should at least be a CT scan where we see lateral and third ventricle dilated and the fourth ventricle is not dilated. T2 weighted sagittal image is the most favorite image for me to decide, because it not only gives you a good idea about the dilatation of the ventricle and the bowing of the floor of the ventricle, but also gives you an idea about adequacy of the prepontine space where you are going to open your third ventriculostomy. Typically done with head slightly elevated, a precoronal burr hole about 3 centimeters lateral to the midline and just anterior to the coronal suture. Burr hole is about 6 to 10 millimeters in diameter because it should take a scope depending on what scope you are available. We typically do it with a 2.7 millimeter pediatric scope, but you can do it with an adult scope. It's not such a big deal unless the cortical mantle is very, very small. You might get an increased CSF collection at the site of surgery if you use a larger scope. Dura in infants is used like a flap because it is important to close it. As in relatively older patients, you can open it in cruciate fashion, and most of the times I have always used the rigid scope, but some of my colleagues use fiber scope for some of these procedures, especially if they want to do something more like aqueductoplasty. Foramen of Monro is usually at a mean distance of 4 to 6 centimeters from dura, and that is where we are aiming for. And this we usually achieve by looking at the choroid plexus. So this is how the head placement looks like when you put the head on the horseshoe. And this is the kind of direction you want to take when you want to go to the third ventriculostomy stoma. Endoscope is passed through the sheath. The lateral ventricle is visualized. Foramen of Monro is visualized. Scope is navigated in the third ventricle. Mammillary bodies and infundibular races are identified. And usually a basilar artery can be seen, as we'll see in some of the videos. I hope they transmit well. The intended fenestration should always be anterior to the basilar artery. And what are the favorable features? When you look at the floor, you want to see that the width of the foramen of Monro is more than 4 millimeters. The floor of the third ventricle should be thinned, and there should be some downward bulging, and basilar artery should be posterior to the mammillary artery. And this is a typical case. You are looking at the foramen of Monro entering the third ventricle. You can see the infundibulum. You can see the opening. The membrane is nice and transparent. I don't use energy. I just use the unipolar just to make a opening and then dilate the opening with this. And then you can see that you are in an unobstructed prepontine space with the basilar artery. Sometimes the floor may be thick, you may not be able to see the basilar artery very well. So the best thing is to feel the posterior clinoid or clavus, and once you feel it, you gently slide your whatever you are going to use to make the hole. As you saw, I've used a unipolar, but again without energy, and then dilate the foramen with the Fogarty balloon catheter. I typically use a 3 to 4. If I use any other scope, I can use a 4 millimeter. For a typical pediatric scope, you cannot use more than number 3 French balloon. And you can now see the second membrane, because the second membrane is equally important, and unless you have ruptured the second membrane, you have not done a proper stoma, and therefore seeing the nude basilar artery is very, very important for success of your stoma.
Excuse me, Dr. Chan.
So puncture usually.
Hello,
Yeah.
Dr. Chen. Are you trying to share your screen? Yes. You're not sharing your screen. I'm sorry, I didn't pick that up. Are you trying to share your screen? We're not seeing any slides.
Okay.
Did you want to show?
I'm terribly sorry about that. Do you want me to go to the beginning again?
No. You can continue on, but just, start where you left off there. Because your descriptions are pretty good. I didn't really pick up the fact that you wanted to show screens.
Just give me 1 second.
Yeah, sure. Sorry, folks.
Can we see the slides now?
Not yet. Not yet. You're sharing the wrong screen. Just pick on. There you go. Yeah, perfect. I'm sorry.
We are
folks.
better now?
Yes, we can. It's perfect.
Now?
Yes.
Okay. So usually make the ETB puncture between the midway between the mammillary bodies and the infundibular races, and dilate it to about 4 millimeters and see the nude basilar artery to do that. And I usually check this with a CSF flow study at the end of about 3 months, which can be done on any MR above 1.5 Tesla. Some unfavorable features where you should not attempt a third ventricular ostomy would be AVM or tumor obstructing the floor. Enlarged massa intermedia may not allow you to reach there, and basilar artery ectasia does not allow you to be safe. What happens in a thick floor? We have seen one example. This is another example. Again, feel the clavus. Gently slide down the clavus with your blunt instrument, which typically, as I said, is our monopolar coagulation. And then put the balloon and blow the balloon over there, and try to get a 3 to 4 millimeter opening into this layer. And one of the key things is to make sure that you have kept it at a sufficient place. And now the second membrane, and you can see how the second membrane has been opened up now, and now I am comfortable. Now I know that I have been able to actually get into the prepontine space properly. You are seeing basilar perforators beautifully, and you can see the parent artery as well. So you need to be patient. You need to be sure of your bony landmarks before you do that. Sometimes there is a problem in a thin floor. This is a very thin floor. You can see the basilar artery quite well. All the perforators are seen. But in such a patient, I am having difficulty in putting the making a hole, because it is too resilient. It is just trying to sort of go along with my opening, and it takes a persistence, and eventually I have opened it. If you have a stylet in your Fogarty balloon catheter, you can use that itself. You don't have to use any other instrument. And here the second membrane fortunately is not so important, and I have got a good opening over here. This is a patient where it is a post-infective patients, and these are some of the patients which are seen in India and Africa very frequently. This is a tubercular meningitis patient. You can see some nodules, you can see some adhesions, like what you are seeing here in the foramen of Monro. And then after following the choroid plexus, making sure I am at the correct place, I am entering the third ventricular floor, and you can see that the third ventricular floor is quite, you can see small like ependymal tuberculosis, and then I'm actually trying to see where is the opening, and you can see from the basilar pulsations that you are in the correct place, and I'm now trying to open this space. Now, after this, it is equally important to see how bad is the scarring in the prepontine space, because if you really have a very scarred prepontine space, you may not be able to do it. If you have a lot of adhesions, like you see, and you are now seeing the 6 nerves on both the sides, and fortunately, I don't have too many adhesions here, and it worked out very well for this patient. So in post-infective patients also, it may work out well if you have a burnt out disease and if you have a good opening into a clean prepontine space. It may not be always possible, and we feel that in our hands it is about 30 to 40% patients where you can do it in post-infective hydrocephalus. This is a typical case of post-hemorrhagic. Again, low success rate, as we will see later on. You can see these are some of the spots which show the ependymal staining because of this. And here again, I'm having difficulty in how to perforate this in a small place, but eventually managed to perforate with the Fogarty balloon catheter itself. And then I'm entering the prepontine space, and you can see that it has been fairly well opened. Pectoral glioma is probably one of the best indications. You get a very good anatomy. The third ventricle is nicely enlarged. You have a good prepontine space, and the only problem is that you may not always get a very good prepontine space. And as I have already said, you slide down along the clivus, but I'll show you a very small space and what we have done here. So I'm entering the foramen of Monro here. You can see that the space is very, very small. We are trying to see if we can do aqueductoplasty, but aqueduct is completely blocked. Here, we are trying to make the opening a little behind, which is usually not a good idea unless you can make sure that the basilar artery is not coming in your way, and then you can keep on enlarging the space as it has been enlarged later. So right from clivus to the mammillary bodies, the whole area could be opened, and this can happen in some patients. This is the second membrane, as you can see, and eventually that has also been ruptured by just expanding the balloon. We have some other ways that you can actually open this space further if the balloon inflation is not good enough, and in some cases, especially when it is thick, you may have to use a scissors to open this. Always make sure that you use an instrument after being very sure that you are not cutting something which is not clearly visible. So only one blade of the scissor usually moves, and that should be on the top, and the unmoving blade should be at the bottom. And then we have been able to dilate this further, and you can see that the basilar artery bifurcation can be nicely seen over here. Some of the advantages of doing third ventriculostomy is where patient cannot tolerate a shunt. This is fortunately not a very common thing, but this is a young man with a silicone allergy. He's 20 years by the time he's presented to me, with a history of 16 shunts being performed so far. With several revisions, he actually had 4 shunts when he came to us. 2 of them were functioning and 2 of them were lying, in fact, open when the skin had broken because of the allergy. And his pattern of hydrocephalus seemed that he had third ventricular enlargement, lateral ventricular enlargement, a little bit of cyst in the quadrigeminal cistern, and fourth ventricle wasn't filling up at all. And this is what you see. You are virtually blind when you are entering, and you'll probably be able to find. So I use navigation in such cases. Navigation is quite useful to put you, this is the third ventricular floor, which is also confirmed by the navigation. Again, no normal landmarks at all. So we decided that first we are going to open his quadrigeminal cyst, I think this is what we'll do in the next. This is the cyst which has been opened, and after opening the cyst, I have come back to the third ventricular floor, and under navigation, after making sure that and getting a good feel that I am just behind the clavus, I am able to make this opening. I think this is not something which you should try in the beginning unless there has been a reasonably good amount of experience. A blind kind of a third ventriculostomy is not really a good idea to do. The balloon is being used to dilate the opening, and here you can see the prepontine space and further opening of the second membrane, and eventually we got a good prepontine space here after the second membrane has been opened. The basilar is seen, the second membrane is also pretty thick, and I have just been able to make a small opening over there which was later enlarged by scissors. You can see that the good CSF flow through the ventricular stoma, and all the sulci have opened up, though the ventricles take quite some time to diminish. A small opening, you can probably not put the scope through the foramen, so I put the scope at the foramen and then just advance the balloon to open the third ventricular floor, and I have actually taken out the sheath and gone inside with the scope alone and made sure that I can enter the prepontine space. Another patient who has presented with a large pseudocyst coming up to here, and this patient was shunted earlier, and what we have tried to do here is to do an aqueductoplasty. So whenever there is a trapped like fourth ventricle, we add aqueductoplasty to the third ventriculostomy. I think I'll just quickly show the aqueductoplasty. This is the third ventriculostomy first. And so that the fourth ventricle does not remain isolated, we also put a aqueductoplasty and keep the aqueduct open by that method. Okay, we can now look into the fourth ventricle here. This is a post-operative scan, and this patient has remained well following this surgery. You can see the communication between the cyst and the fourth ventricle here on the immediately post-operative scan. Re-ETV, there are some patients where we have attempted it second time. This is a post-infective hydrocephalus. You can almost see the scar on the third ventricular floor, and we have opened this with the scope itself. There are a couple of scopes which can be used directly, which have a blunt tip, and here we have been able to make a good opening. And this child I had operated several years ago has developed quite well. There may still be some situations where you may have to abandon your third ventriculostomy, like a post-inflammatory distortion of anatomy, thick third ventricular floor, and cloudy CSF, which makes for poor visibility and makes it not, virtually impossible for you to do that. Hygromas after ETV are a common nuisance, especially in neonates, and especially when there is a thin cortical mantle, and it is less common if you use a small endoscope. We usually try to treat this conservatively. Very rarely, in fact, I have had 2 patients where I have had to close the tract to get rid of the subdural completely. Endocrine outcome in these patients, there are certain number of patients where there are some hormonal abnormalities, but most patients settle down, and fortunately it's not a very common phenomena associated with third ventriculostomy. The biggest problem I think with this procedure is how is success defined, and I think the only way you can say that your third ventriculostomy is successful is if you can say that you have avoided a shunt in a patient who would otherwise require one, rather than looking at the normal intracranial pressure and other factors. And what is not clearly defined in this definition is how long do you wait to say that it has been successful or not. And we usually say that there are late failures which are possible, and you have to wait at least a year. We have 2 patients who have actually failed after 1.5 years. But I think usually a year, if you have not been, you have not needed to put in a shunt, I think you can say that your procedure has been successful. The radiological recovery is usually very slow. It has been studied quite well, and the reduction in ventricular size is seen to 10 to 50% by the end of first week. Periventricular lucencies classically disappear in about 3 weeks' time. CSF flow artifact is one of the most common ways to demonstrate that your stoma is open. The bulging third ventricular floor straightens down, and most of the diverticula, the suprapineal races, they all become rudimentary, and the cerebral sulci start looking much better. Third ventricular size reduces 30 to 40% after first week. The lateral ventricles reduce much less and take much longer time. And in some patients, you may not see a substantial reduction in the ventricular size. Typically, what you want to see is that the bowing of the corpus callosum has become less. The ventricular size has reduced. You can see the stoma being open, and you can see that these kind of sulci, which were full earlier, have now become much more prominent to see. There are various predictors of outcome which people have studied. Age, etiology are the most probably important, more important than cortical mantle, I suppose. And Abhay Kulkarni and colleagues in Canada, after studying I think over 3,000 cases, have actually come to formation of this score, which is called ETV success score, where you add age score with etiology score with a previous shunt score, and it probably gives you a good percentage probability of ETV success. And this is the formula which it says that if you have a score of 50, and if the patient's age is patient's age over 20 years, you have aqueductal stenosis, tectal tumor, or other pathology, and no previous shunt, you have virtually 100% chances of success, which reduce depending on what is the pathology. The worst case being age less than 1 month, post-infective pathology, and the previous shunt insertion. Like every procedure, there are complications which are possible during third ventriculostomy. The most worrisome is, of course, the vascular injury, but before that, a fornical injury. If you do not use your scope well, or if you keep it tented for a long time, the foramen of Monro can get distorted with fornical injury. Vascular injury, of course, is can be fatal, and you have to avoid it by the various ways we talked about. Don't push in any sharp instrument. Use the balloon to dilate your stoma, and hypothalamic injury can be avoided by placing your stoma correctly. Infection, CSF leak are other problems which are procedure related, but which are also related to the general operation theater infrastructure, and you need to have a very properly sterile OT as much as inserting a shunt. There have been several, I think, complications described as we talked, but one of the most important things that has been shown by Schroeder, Gaab, and colleagues is that the first few procedures are probably more worrisome because of the dexterity of the procedure. Apart from that, even your choice of cases change. And in their first series of 193 patients, they had up to 15% morbidity and about 9% of asymptomatic complications, while in the last 100 procedures, it has come down to almost 1% of morbidity and less than 5% of asymptomatic complications. People have tried to do in utero ETV, which has not been very successful. Age as an independent factor has been studied, I think, the most extensively. Recently, the IFNE has produced figures for an international study on the age of the patient and recommend that ETV can be safely and more effectively done above the age of 6 months. This is another paper from Chicago, which shows that the crucial time probably is 3 months, with Patients with aqueduct stenosis above the age of 3 months are probably giving as good a result as above 6 months. I think aqueduct stenosis probably is an ideal indication. In hydrocephalus and spinal dysraphism, the success rate is not very good. And what has been brought to notice by Jones and colleagues is that though the first time ETV has not worked in more than one patient out of the 11 which they treated, if these patients present to you with a shunt failure after the age of 1 year, the delayed success rate is almost 80%. Similar thing has also been shown by Ben Warf in his series which he has conducted in Uganda, and he has shown a success rate beyond 60%. He adds choroid plexus fulguration to the ETV for many of these patients, and similar success rates are now being found by other workers also across the world. One of the main reasons why this probably happens is the absorptive capacity of CSF is poor, and therefore in patients where the primary success rate is only about 23%, as the age advances and if you do it for a shunt block, the delayed success rate can increase to almost 77%, shown by Grottenhuis and others. Dandy-Walker syndrome, about 50 to 75% success rate people have shown. In Chiari malformation, there are very few cases but have shown more than 50% success rate. In post-hemorrhagic hydrocephalus, if the pattern of hydrocephalus is obstructive, you can get about 50% success rate, but not a very good indication. Same for post-infective hydrocephalus, as we talked about earlier. Series from India, from AIMS and GB Pant in Delhi, Lucknow, they have all shown about 40% success rates. Similar work from Fegan and colleagues in Cape Town have shown the same. Tumoral hydrocephalus is probably a very good indication to do a third ventriculostomy rather than going for shunt. Either before surgery or even after surgery, you can get up to 60 to 70% success rate. Pineal region tumors, of course, is probably one of the most predominant indication in our practice, because it also gives us opportunity for tumor biopsy and CSF sampling. We have found that in the last about 27 patients we have done for the secondary ETV, that is whatever may be the primary etiology, if we have done it for a shunt failure, our success rate has been about 70 to 80% in this patient, and this is predominantly dependent on the radiological finding that the lateral and third ventricle are large and the fourth ventricle is not so large. Other indications of predictors of outcome is CSF leak through the wound is found to be universally a bad predictor. Response to lumbar puncture has been found to be a good predictor. When do you say that the ETV has failed? I think early ETV after drainage LPs for 3 to 5 days, if things have still not worked, you should be checking stoma, and depending on if the stoma is closed, you have to go for a shunt, and if the stoma is open, if the stoma is open, you have to go for a shunt. If the stoma is closed, you might try a re-ETV at least once. Korean group has shown that ETV plus shunt in very young patients might work well in synergy. Long-term results, as shown by the people from HSC Toronto, show that though the initial cost may be a little higher for a third ventriculostomy, which is actually not true in the developing world, because most of the cost is of consumables. They have shown that over a period of about 5 years, they even out. The main reason being repeated shunt revisions probably take a big toll on these finances of these patients. Neuropsychological outcomes, I think, have been mainly sort of related to the cerebral cortex rather than and the primary pathology, rather than there being any difference between ETV and shunt. Neuropsychological test results, again a similar thing. Patients with shunt and patients with ETV have performed almost equally well in the Canadian study, and same for overall quality of life issues, which again has been written up by the Canadian. So we tried to show you the various aspects of third ventriculostomy, when it is applicable, what is the right way to do it, and what complications can occur, and what do you expect in terms of outcome. And I'll be very happy to take questions. Thank you very much.
Thank you very much, Dr. Chan. Another great presentation. Okay, Ismail, you want to take over?
Anyway, but I can open the session for questions. If any audience has any questions, any questions? Where's online? John.
Yes.
Any questions?
Can you hear me okay, Ismail?
John, Mr. Chandra, after 20 of endoscopy progress, do you think the tradition can still have a place?
These procedures, as you must have seen, have been done with 3 different endoscopes. They have been done by Esculap mini scope in the initial period, but more recently, we are using either the OE Handy Pro, which is a 2.7 millimeter endoscope by Storz, and the little Lota, as they call it, what is a high definition, after the high definition camera has been introduced. So these 3 scopes have been used for many of these procedures.
Okay, thank you. So
one other thing you must have noticed.
I think no more question right now. We are going for a coffee break, and we can resume our second session in 25 minutes. Is it on?
Okay, it sounds good. Thank you, Ismail. We'll see you in a few minutes.
So, thank you for your guest. Great presentation, a great session. We are closing the first session right now and going for a coffee break. Going to invite you, but the distance. So just have yourself and let us meet in 25 minutes.
Okay.
Thank you very much.
Very good. Dr. Chan, don't leave yet. Okay. Okay. Very good. Okay. Dr. Chan, you can just get off the screen share, clicking on the green arrow. Click on the green arrow.
Okay, John, speak in 25 minutes. I mean, we have 2 locals and 2 from your side.
Okay. Okay. I'm going to stay on, and you come back when we need to start again. Okay.
Yes. Okay.
Very good. I'll be here.
Are you okay?
Okay, Dr. Chan. Dr. Chan, please click on the green arrow on the left-hand side of your screen to get off the screen share, so we can see your face. There we go, Dr. Chan. Did you enjoy yourself?
Yes, it's been nice. I'm sorry that first few slides went missing.
No, that's okay.
And
you know, it's like a neurosurgical procedure. It's new, and we're new at this.
Right. I hope it has been useful, and if I come across again to Miami, maybe we'll meet.
Well, Dr. Chan, I'd like to do more with you because you're certainly a great neurosurgical teacher, and I'm sure these students and residents don't know how lucky they are to have you, and I hope we can use this platform to get your face popular in the neurosurgical world.
Happy to help, John. I just wanted to ask you one other question.
Yes.
You are putting these on the YouTube, is that correct?
Yes.
How are they accessible? Are they accessible to everyone? If I want to see it at any time?
Yes, they're for the public domain. They're forever. They're free. They're public.
And our channel is called Neurosurgical TV, right?
Exactly. They're all accessible there through the conference part of the menu, and this obviously will be labeled Yemen Conference, and your talk, we're going to edit them, and we'll cut out the parts that don't look too good, and we'll put it on YouTube after we edit them.
So if anybody wants to have a look at it, I can ask them to refer to this.
Yes. Yes, I'm gonna send you the link both before and after it's edited. And please feel free, if you want to give a lecture to anyone, to get in contact with me. We'll set it up. And
I will talk to them. Certainly, and I'll get back to you on this.
Yeah, and anything you need, Dr. Chan, let us know.
Great talking to you, John.
Okay,
Bye
nice to
for
thank
now.
you for coming back today. Thank you. Okay, very good. Okay, we got a short break here for a coffee break in Yemen. The next talk is with a microbiologist, and I have to orient him onto the platform. And let me hear. We're gonna edit this out, Marco. What do you think, Marco?
It was amazing.
Sí,
I really
los
liked
estudiantes
the endoscopy.
sí,
I really liked
este hombre, Marco, es uno de los mejores maestros en neurocirugía en el mundo. Pues él entrenó en Canadá, los Estados Unidos, India, Alemania, y él le gusta enseñar. Qué lástima el problema, pero hey, es así, es nuevo. No, es nuevo.
Sí.
Es nuevo. Ok, déjame ver la próxima persona.
Ok.
Es de Malasia. Imagínate, Malasia. Es hermano de. Oh, my God. Yo creo que probablemente no está usando. Probablemente no va a venir. Malasia no tiene Wi-Fi y no va a gastar tiempo con Wi-Fi. Yo he hecho una vez antes con Wi-Fi de Malasia, es horrible.
Wow.
Es mejor que no hace. No pierda su tiempo. Yo voy a decir, si no puedo, ok. Entonces, la próxima, después de esto, ok. 1, 2 de Congreso va a televisar y un hangout después, almuerzo para 1 hora y media y 2 más televisando, no hangout. Oh, la última es un hangout. Okay. Pero Deepak es bueno, ¿eh?
Sí.
Rápido, información, rápido. Boom, 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 boom.
Sí. Ha corrido.
Sí, déjame ver cuánto tiempo está usando. Vamos a estar vivo.
Hola, Marco.
Ah, finalmente. No me creo.
Sí, sorry. Es 2 de la mañana.
Oh, Mauro, ¿cómo estás?
Bien, ¿dónde estamos, Marco?
Yo creo que es otro hombre. Estoy esperando.
No, soy yo, Mauro.
Ok, espera.
Marco, ¿en dónde está Marco? Ah, Bolivia.
¿Cómo está, doctor? Saludos, profesor.
Ah, qué bueno
Muchos latinos. Muchos latinos en Yemen.
Latinos con insomnio. Marco, ¿tú eres médico?
Sí, yo egresé hace un año, doctor. Terminé la universidad. Estudié en la Universidad Mayor de San Simón, acá en Cochabamba. Terminé hace un año.
Medicina. Sí. ¿Y quieres hacer neuro o investigación?
Neuro, doctor. Sí, me llama mucho la
atención. Pues ahí tienes un excelente amigo, Geider Salas.
¿Acá en Cochabamba?
Ah, no, ya me acordé, está en La Paz él.
Ah, ok. No, yo estoy acá en Cochabamba.
Bueno, Oye,
Usted,
¿y
doctor,
cómo le hago
¿dónde se
para
encuentra?
poner
Allá.
mi nombre abajo? Ah, ok, ya empezaron, ¿verdad?
No, todavía. Se va a la parte izquierda y hay un icono que dice Toolbox. ¿Lo tiene?
Tengo el azul, el verde, unas cabecitas y una maleta.
En la maleta. Le
Ok.
hace clic y le salen el display name es para poner su nombre completo. Y el tagline es, bueno, puede poner de dónde se encuentra o dónde trabaja. Y en la parte de abajo, Upload Overlay es para cargar la foto. El icono azul, el de abajo. Le da clic y carga una foto. Para activarlo, se va en la parte de arriba donde dice Lower Third y mueve ese icono hacia la derecha. Es un botoncito, uno azul. Lo mueve a la derecha y se activa lo que escribe.
Ah, ok. Lo que pasa es que me está pidiendo permiso para iniciarse. Creo que le doy que sí, ¿verdad?
Sí, sí, doctor.
I'm trying to get this guy from Malaysia here.
He's ready?
No, he's trying to get in now. He's still trying.
Okay.
I think he's a microbiologist.
Wow.
He's the brother of Ismail, the director of the conference.
Oh. He left. And he's back. ¿Logró, doctor?
Ahí está, ¿verdad?
Ah, aquí está.
Exacto.
Hey, su entro.
Exacto, doctor.
Hola, ¿cómo estás? Abdel. ¿Puede oírme? No sé si conexión es buena. Abdel, ¿puede oírme? No sé. A veces cuando la conexión no es buena, el audio no sirve bien. Abdel, ¿puede oírme? Ok, estoy comunicando por... Ok.
Sale al revés mi nombre, Marco.
Es normal, doctor. Nosotros lo vemos girado. Si quieren, hay como un celular ahí con una flechita pequeña al lado del botoncito. Le da clic y va a girar para usted.
Ah, ok.
Sí.
Ok.
Pero nosotros lo vemos bien. Sí.
Bueno, voy a salir y ya con calma te contacto, Marco. En agosto es el Congreso Mexicano.
Ok, doctor, perfecto.
Yo tengo un simposio y tenemos otro en Miami con Valerio.
El
Ok,
No sé si
bueno.
ya hablaste con Valerio para que podamos transmitirlo.
Sí, sería genial. Sería increíble, doctor.
Sí, yo quiero televisarlo si José quiera. No sé si él quiera, no sé. Porque a veces personas con congresos no quiero porque quiere que vende boletos, ¿verdad? Y no sé cómo es con eso.
Hay tiempo, el de Valerio es el 5 al 8 de julio.
Sí.
Entonces,
Sí,
Valerio visita el Arkin.
Tal vez yo voy a preguntar a él si quieres. Porque a veces no quiere. No quiere diversión, quiere concentrar en llenarlo con personas. No sé. Oye, Abdel, ¿puede oírme? Dos conexiones usando un iPhone probablemente. Well, Abdel, are you can you hear me at all? Can you hear me? Okay, let me chat with him on. Oh.
Ok, guys. Buenas noches, John. Buenas noches,
Ok,
Marco.
gracias, Mauro. Tengo un buen sueño.
Gracias.
Gracias,
Hasta
doctor.
mañana.
Hey, Mauro,
Hasta
Mauro, si quiere televisa, algo dígame, ¿ok?
Sí, lo vemos con tiempo, John. Gracias.
No, mira, Mauro, hay un cirujano en Nepal, él va a televisar muchas operaciones de sala de operación. Tú conoces a Ip Cherian, ¿verdad?
¿No?
So, well, él
Pero-
va a empezar televisando muchas cosas allá. Entonces, tú vas a ver más operaciones vivo allá. Porque no hay tanto leyes allá, no hay tantas restricciones como los Estados Unidos. Y yo creo que ahora está instalando equipo muy bueno para televisar. Con permiso.
Sí, yo creo que hicimos una cirugía que se transmitió hace un mes. Ya la vio Marco ahí en mi página, pero podemos transmitir desde el Pentero.
Ok.
Tengo que checar las cuestiones técnicas.
Ok, vamos a hablar sobre eso.
Ok, John.
Ok, buenas noches.
Buenas noches, John. Buenas noches, Marco.
Saludos, profesor. Buenas noches.
Gracias.
Ok. Abdel, no puedo oír. try to come in again, Abdel. Reboot. Okay, un sandwich.
Ok,
Va bien hoy, ¿huh?
está excelente, doctor.
Sí, esta dama inspiración. Cuando la gente como Dr. Chan y Dr. Gupta vienen para dar presentaciones de primera clase, en Yemen ellos tienen suerte para oír a estos hombres. Porque ella no va a viajar a Yemen. No va a viajar. Y gracias a Mauro también. Mauro y
Víctor.
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 Wow. Lo Víctor. Probablemente ella no ha visto anatomía así. Como Víctor. Es diferente que normal. Ok, espera. Yo regreso, ok. Guarda mi casa.
Ok.
Hola, Abdel. Hello. Abdel, can you hear me? Can you hear me? Okay, I guess you can hear me and see me. Try to go to YouTube to see if you can hear that video. The camera's not even turned on. I don't even know if you.
من هنا صار من الداخل صح؟
محاضرات من داخل ايه.
الدكتور.
Hello.
شو المحاضرة؟
Okay, it's the same link. It's the same link.
هذا؟
Hello, gentlemen.
فيديو. ثلاث محاضرات محلية. ثلاث محاضرات. حق ايش؟
اخر كيتس 5 minutes.
ايش حق كيتس؟
عندنا 5 دقائق لل
Hello, Mr. John. Dr. John?
Yeah.
Can you hear me?
Yes, I can hear you. Yes, I can hear you. Can you hear me? Can you hear me okay?
I can't hear you.
You can't hear me? Okay, it's something wrong with your microphone. Can you see me? Can you see me?
There is no sound and I can't hear you.
Okay.
جاهز اعتقد.
الصوت مش جاهز. الصوت من طرفه مش جاهز.
ما في صوت هي ولا ميوت عندنا؟ شوف ميوت.
مش ميوت، هذا ميوت.
You can't hear me? Can you see me?
شلون؟
Yes. Hi. Can you hear me? No. I can hear you. I can see you. Reboot. Reboot. Reboot.
كلمته.
Hello, can you hear me now? 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 Testing 1 2. No. Reboot. Reboot. Reboot.
ايش مرتاح؟ مش مشكلة.
عندهم طرفين. في طرف عندهم مشكلة هناك. هذا من كويس.
مش تحكم المكان وصلتوا؟
بس واي ايش الفيسبوك شغال هنا؟
Testing 1 2. Testing 1 2.
صباح الخير.
جي هذا دوس
هذا شو
ثاني اثنين
واحد بس مش غير
واحد ثاني
ما فيش غير يا حبيبي واحد عامل دبل هذا
جون بيت مسج
شوف شو المشكلة تتبع الصوت
هو عمل ميوت من عنده بس المفروض يطلع عندنا. Okay, I can hear you and see you, but we can't. Says your brother Ismail can't enter, and we have to cancel that one. You get out of the system.
اوكي ممكن محاضرة لايف.
Okay.
او اذا معها الفيديو طبعا لا ضرورية فيها فعل alternative. اوكي كان هذا اوكي.
Do you have off?
السيشن الخميس صعبين عنده. Yes.
Yes. Or we can do a little so I think I'm looking at it. You can do the Rahim will present their document.
Okay.
You can do this next two without hitting me. We can't do this next two.
Okay, بس ليش؟
without hitting me.
كويس نبدأ.
Okay.
إبراهيم. خلاص نبدأ إبراهيم. Okay, we'll start the first one.
We will start with okay.
خلاص نبدأ. اوكي. نقدم إبراهيم.
تمام. هي شغل البرزنتيشن.
Ladies and gentlemen, we are going to
management of finance.
To carry on the second session, and that we have some technical issues with Miami. We are going to proceed with Dr. Ibrahim Jum'an in his presentation about administrating injuries. Ibrahim, he is one of our good residents in the last year in the Arab board. He's working very hard, and he has developed himself very in a good fashion. And now you can see how good he is. A good speaker. Ibrahim Jum'an will going to present us his lecture in a fast way. Go ahead, Ibrahim.
Just click close.
بسم الله الرحمن الرحيم. Our object about management of penetrating spinal injuries. Speaker Ibrahim Jum'an Al-Hamd, under supervision of Dr. Ismail Al-Kibsi. About the object, this study to analyze presentation and location modalities of management and outcome and complication of the penetrating spinal injuries. Introduction. Penetrating spinal injuries are the third most common cause of the spinal cord injury, exceeded only by motor vehicle accidents and falls. Most of the early experience with this neurological management of penetrating spinal injuries was guided during gained during wartime. The main prognostic factor considered for recovery is the initial neurological manifestation, and so the patient with incomplete deficit have functional or superior functional prognosis compared to that presented with complete spinal injury. The initial approach of the gunshot wound to the head, to the spine should follow advanced trauma life support and principles. Approximately 25% of all missile injuries to the spine will have associated systemic injuries. This schedule shows table distribution of effectiveness of the gunshot in Brazilian studies. The study showed the main high incidence of spinal penetrating injuries at the age between 21 to 30. All studies said that. In 1988, estimates of prevalence indicate that there were 21 cases of spinal cord injury per million population. Data from the major trauma outcome study shows that penetrating spinal injuries account for 14.6% of these acute spinal cord injury. The National Spinal Cord Injury Database reveals a mean age at the injury of 29.7 years at male to female 4 to 1. This study also of 1,000 cases of the spinal gunshot show incidence of the 18.4% of injuries associated with spinal trauma. And the most common frequent complication or associated injury of this spinal penetrating injuries was hemorrhagic. Also, this table shows distribution of the gunshot wound in the spine according to the spinal level. The most common site for injury was thoracic region in all studies. Approximately 40% of these injuries was shot in the back, as compared to only 19% in whom the missile entered anteriorly. The incidence of penetrating injuries to the spine has increased lately, and they cause 13 to 17% of the all spine injuries. During World War I, the overall mortality rate from a missile injury to the spinal cord was 71.8%. The mortality of penetrating spinal cord injury in the Second War decreased to between 7.4 to 14.5%. About classification of the penetrating spinal injuries or gunshot to the spine. This classification, type 1, type 2, type 3, type 1 transfixing or small fragment in the spinal column and the bullet go out. Also type 2, when the bullet inside the canal, and type 3, when the bullet inside the intervertebral space. Also, these three subtypes divided also in subtypes in A and B. And type 1, grade 1, grade 2, grade 3 is divided to A and B according to if there is any visceral perforation or not. Different types of gunshot wound in the spine. This is the first one. This is transfixing, which is the most common type. The middle one is in the spinal canal. The third one is the intervertebral disc. The period of the follow-up to consider the functional status of the patient as definitive is a matter of controversy in the literature, varying from 2 weeks to 6 months. The management protocol consists of once the patient has stabilized, so history is obtained and detailed neurological examination is done, the level of the spinal cord injury and American Spinal Injury Association grade, what we call ASHA grade, are documented immediately. radiological assessment to assess if there is any instability or compression in the spinal cord, and administration of the tetanus vaccine and antibiotic and wound debriding. About corticosteroids is not benefit and should not be
Dr. John.
Oh, sí. Oh, yes, sí, sí. Sí. Oh, what the fuck? Yeah, that would be a good one. Uh,